Okay, good morning, good afternoon, good evening, and hopefully not too early morning Saturday to some of you. Thank you for joining us at the Axiom think tank today. Hafiz here with Axiom. Our guest needs no introduction. Thrilled to have Dr. Rugo from UCSF joining us at the think tank table again. Happy New Year, Dr. Rugo.
Happy New Year to you as well.
I was just looking through some of the old script and data. You and I have been doing this for the last 9 years almost.
There you go. I would have guessed somewhere close to 10 years at this point.
Yeah, and we have seen a lot of changes. I was remembering the day when we presented at ASCO and folks were confused about PCR versus PAT-CR and the huge data points we had shown and so many other trials and studies. So it'd be kind of good to go back memory lane and see some of the trials that we have seen, some of the trials that has shown great results. And to your point, some of the trials that were a little disappointing, but there's a lot to be learned from those trials as well.
Absolutely.
Good. So shall we jump into early TNBC to begin with?
That sounds good.
Perfect. What were you excited about early TNBC in the last years and last year, some of the data that you have seen? What gives you hope?
It's an interesting thing to start with early TNBC because, of course, as we go on after San Antonio, we're asked to do a lot of San Antonio updates and recordings, et cetera. And one of the recordings assigned me to the topic of metastatic TNBC, best of the year. And I thought, what am I going to say about that? Some new drugs, but nothing that we can take into the clinic yet, unfortunately, this year. I mean, we have had big advances that have improved survival in metastatic disease, but where we've really made, and I think rightly so, the biggest progress is in early stage disease, where I think we started with the idea of what's the right chemotherapy backbone. And I will say that we don't know that for sure yet, and that's still an area of further investigation. But the idea came from other studies which showed great success with adding immunotherapy checkpoint inhibitors to chemotherapy for drugs that were known to be immune active. And I think that's really important as we think about the historical implications here. And what we've learned is that breast cancer was thought to be immune inert, really, or sort of a cold, and we call it cold environment. And the issue there was that you would have to learn how to teach the immune system of the host to see the cancer as foreign, or you have to generate some change in the cancer to make it be an immune stimulant for the body. So that was the huge challenge. And that's really why breast cancer is one of the later cancers, despite being the most common cancer in women diagnosed worldwide, with which we've really seen big studies that now have resulted in approval of immunotherapy. So why triple negative disease? It represents about 15% of breast cancers, and triple negative breast cancer is a cancer, still a huge unmet need, where you really just have chemotherapy to treat patients and nothing more. And if the cancer is resistant to chemotherapy, and in these subsets where the cancers actually grow on what we know to be effective chemotherapy, we don't have any kind of effective rescue mechanism for these cancers. So that was an obvious area to start looking at. And then we found out that triple negative cancers actually had this immune rich environment. Not all, of course, unfortunately. Some of them have this immune desert like environment. But many of these cancers have infiltrating immune cells called tumor infiltrating lymphocytes, and they have markers on the cell surface that indicate that they are more immune responsive. So we saw great success in our initial early phase trials in our I-SPY 2 national phase 2 adaptively randomized trial, adding just 4 doses of the checkpoint inhibitor pembrolizumab to chemotherapy, where we improved the number of patients who had no cancers at the time of surgery or pathologic complete response rate, and then showed that those patients did very well. And that led to a study which actually capitalized on another I-SPY trial, one that I published in the New England Journal some years back, where we added carboplatin and saw that the PCR rates increased regardless of whether or not we added a PARP inhibitor or not, as confirmed in another trial called the Brightness trial. So that led to Keynote 522 that has really completely changed the standard of care, and with really exciting results that were presented at ESMO this year. So a trial which added pembrolizumab to the platinum, taxane, anthracycline-based chemotherapy, and first showed improved PCR. And we tried hard through the FDA to get approval from that. And they were like, nah, no, PCR isn't good enough. So then we went and saw that event-free survival was improved, and it was improved regardless of the immune markers, which I think is also really exciting. It didn't matter if you had the immune markers or not, you still improved the PCR and improved event-free survival. And that's critical because for triple negative disease, that always correlates with overall survival. And we saw at ESMO this year, well, last year, 2024, that overall survival was also improved. And what's, I think, key about this study is that it was improved regardless of stage of disease. So if you had lower stage 2, you had to do to be eligible, so greater than 2 centimeters or node positive, but also bigger tumors benefited as well. There was a higher pathologic complete response, higher event-free survival, and higher overall survival. And then we learned a lot from this. So we learned that there was not at San Antonio this year, that there wasn't a biomarker which additionally told us which patients benefited, which is really interesting. And it brings us back to an idea which I hope grows, which is the idea that you should look at the response to treatment and then individualize the therapy based on response, because we know that having no cancer at the time of surgery or very little correlates with better outcome. The second thing we learned, which I think is really such a critical point this year, this last year, is that if you didn't have a pathologic complete response, we know your outcome is poor, particularly if you have a lot of cancer left after getting your treatment before surgery and going to surgery. So a lot of cancer at the time of surgery, we don't have good rescue mechanisms. That's another area I think we'll talk about where maybe some we can improve, I'm sure, on this area. But what we found was that if you had a PCR, regardless of whether you got the immunotherapy or not, your outcome was very good. So that's good. There was just less people who got a PCR without pembrolizumab. But if you didn't have a PCR and your outcome was worse, your survival was better if you'd gotten pembro. Less distant recurrence, less recurrence overall. So that is critical information from 2024, and I think really further establishes adding pembrolizumab for patients who have at least stage 2, early stage triple negative breast cancer. And then, of course, now we know that some hormone receptor positive cancers act like triple negative cancers. They have an immune response. They're not these slow growing, I call them old lady cancers, because they happen in any age, but more commonly as women age. Those slow growing cancers don't have an immune response from the body, and they look like normal cells. But the aggressive hormone receptor positive cancers that we see more frequently in young women also respond to pembrolizumab. And I think we'll cure more women with those treatments for those more resistant hormone resistant cancers as well. So I think the sort of applicability of this treatment is broadening.
That brings me to a question, the PAT-CR. What are your thoughts, it being a surrogate endpoint for long-term benefits? And obviously you brought up some points. How to think about it as we're going through drug development in the future with PAT-CR?
This is such an interesting area because there's a lot of controversy about it. And I think the controversy stems from the fact that we haven't identified the subgroups of patients well enough. And there are treatments after surgery which can impact outcome as well. So if, for example, you look at slow-growing hormone receptor-positive breast cancer, PCR has not been a useful endpoint because these cancers, women can live a long time, women and men with these cancers, and whether they respond to chemotherapy or not is not a predictor of outcome. But for the more aggressive cancer subtypes, the response to neoadjuvant therapy, particularly in the modern day. And I think that is important because we identify the subsets better. We're identifying the cancers that benefit from chemotherapy more. And we are better at categorizing what a true PCR is. It includes no cancer in breast and lymph nodes, and you can have some non-invasive cancer in there. And it's really important that we have all of those things put together. And when we do, what we've seen is that PCR correlates with a much better outcome. And we've seen that from all these recent trials. The FDA still doesn't use it as a primary endpoint, but I think we're seeing that in subsets of patients that it can play a really big role, for example, in triple negative disease. But in hormone receptor positive cancers, there's a lot of heterogeneity. And the use of hormone therapy and now cyclin-dependent kinase 4/6 inhibitors after surgery, and potentially switching to the novel endocrine therapies in studies that are ongoing now, will also impact outcomes. So I think it's going to be a complicated path and needs, a little bit longer follow-up for the immunotherapy trials to understand that impact. But what that means is, and I think you brought this up a little bit, what does PCR mean for our clinical trials? So, we've done clinical trials where we look and we take the patients who don't have a pathologic complete response, and then we randomize them to one treatment versus another. So standard of care versus standard of care plus, or a new, potentially better treatment. But my concern is that that may not be the best way to study these agents. I think it's an important path, but it may not be the best way, because by the time you've gotten through surgery and waited for recovery to start the new treatment, you get an expansion of clones that are more resistant. So they've learned under the pressure of treatment to be more resistant. And so you're essentially hiking up a much steeper hill. So if you start potentially before surgery and base your next treatments on how well the cancer has responded by imaging, biopsies, et cetera, maybe we can even make further inroads into helping the cancers that aren't responding to treatment respond much better. But today in 2025, we're curing more women of breast cancer than ever before. And I think it's really due to these advances in understanding biology and novel therapeutics. But we still, of course, have a long way to go.
Wow, that is just fascinating. And of course, we saw a few studies that were a little disappointing. Any thoughts, any lessons learned that you picked up from some of these studies?
I think the main study that was highly anticipated and was a negative study, so it didn't result in improvement in outcome with in the experimental arm versus the control arm, is the trial called Jeoparduse, or NSABP B59, which was a collaboration really important for us moving forward. I mean, trials, you got to get your trials done, enroll as quickly as possible, and get to the endpoint more quickly, because if you don't, you're just sort of dragging out the question forever. And so we can't bring new treatments that are going to help patients to the clinic as quickly as possible, or not use treatments that won't help patients. So in Jeoparduse, this was the largest neoadjuvant trial for triple negative breast cancer ever done. The Keynote 522 trial had about 1,200 patients. This trial had over 1,500 patients. They added the checkpoint inhibitor atezolizumab to a standard backbone of chemotherapy, very similar to what was done in Keynote 522. And originally they had two primary endpoints, so similar to Keynote 522, PCR, pathologic complete response, and event-free survival, with, of course, overall survival being a secondary endpoint. But they were concerned about their power, and they knew that they needed to have enough power to detect an event-free survival improvement with the addition of atezolizumab. So partway through, the trial was changed to have just EFS as the primary endpoint, or DFS. And that trial was presented at San Antonio this year and showed no improvement in event-free survival with the addition of atezolizumab to chemotherapy in this very large trial. And that was quite disappointing. I think, having been involved in the Impassion 130 trial, the very early trial that showed an improvement in overall survival in patients with PD-L1 positive metastatic triple negative disease, led to accelerated approval of atezo, but then a subsequent trial with a different chemotherapy backbone did not show a benefit, and the statistical design was complicated. This hierarchical statistical design where you have to have a positive outcome in the overall population before you look at a subset. And the way they designed that was that in Impassion 130, OS had to be better in everyone in order to show that OS was better in the PD-L1 positive population. It wasn't better in everyone, but it was positive in the PD-L1 positive population. This represents about 35 to 40% of patients with triple negative disease in the first-line metastatic setting. And so, it makes sense that they didn't have enough oomph to push the entire overall survival. So we were really banking on this to change the ability of atezolizumab to be used in breast cancer in the US, and clearly it didn't. Atezolizumab still has approval in the metastatic setting outside of the United States, but it's no longer approved and won't be approved for breast cancer because this is really the final unfortunate nail in the coffin. The question really came up about why was this a negative trial? And I think that brings up a lot of interesting questions about, is it due to the agent? Is it due to whether the agent is a PD-L1 versus a PD-1 inhibitor? And I think that that's a big question because pembrolizumab is a PD-1 inhibitor and atezolizumab is a PD-L1 inhibitor. Now, I think it's probably unlikely that that's the key difference, but it may be that the agent itself isn't as active. I mean, it's interesting, when we were giving atezo, we didn't see a lot of immune toxicity, but we see quite a bit of immune toxicity with pembrolizumab. So maybe there are just differences in activity. For example, when different immunotherapies are combined in this attempt to try and make a cold tumor hot immunologically, we see this massive expansion in immune toxicities that we haven't really been able to overcome yet, including permanent toxicities like adrenal insufficiency, where you have to take steroids for the rest of your life at a low dose, but still, it's a big change. So, is it that it's just not as active an agent? But obviously, because this trial, Jeopardy's, the NSABP collaboration, was done at a much later time point in terms of starting than Keynote 522, there were changes in how we treated patients. So there was a lot of enthusiasm about using immunotherapy. So there was a few more patients, less than 10% more, but still somewhere in the 7 or 8% more patients who had stage 2 node negative disease. And why is this important? The less cancer you have, the better your immune system is at working with chemotherapy to kill the cancer. It's interesting, the more cancer you have, the greater your cancer burden, the more the cancer suppresses the host immune response. So when we looked at PCR rates, we saw that the benefit of pembrolizumab was greater in stage 3 disease than in stage 2 disease, even though there was benefit for EFS and OS in all groups, and the outcomes worse in higher stage disease. The relative benefit potential to those patients is even greater. So could that make a difference? I mean, it's less than 10% difference in patients. And when you looked at subsets of patients, there was no benefit in any subset. So unlikely. Could it be that more patients received post-neoadjuvant capecitabine compared to when Keynote 522 was done, when capecitabine wasn't allowed and it was brand new? This is all based on the CREATE-X trial that showed a benefit in outcome in triple negative disease using CAPE in that setting. But we know that the patients enrolled in CREATE-X were a little bit different in that Asian patients with triple negative disease have less of the basal-like highly resistant subtype of breast cancer. So we have seen in clinical practice that capecitabine, I give capecitabine to my patients, they all recur with metastatic disease, the bad cancers. So I don't know that capecitabine alone is enough to make that explanation, but regardless, that's what happened. Half of the patients received capecitabine. Also, we maybe due, the benefit that was quite big in the Japanese and Korean population, maybe due to a difference in subsets of triple negative disease. And, I think that we'll learn more about that. In the basal-like group, a trial published by Ingrid Mayer showed that only about 40% of patients were disease-free at 3 years if they received capecitabine, or they also gave carboplatin. So capecitabine doesn't have a huge impact. And then there's one other aspect that was brought up as a potential, I don't think is likely, which is giving every 2-week anthracycline-based chemo versus every 3-week. That wasn't allowed in Keynote 522, but it was up to provider choice in the atezolizumab trial. And so a lot of people got every 2-week AC or EC. anthracycline-based chemo. Again, very unlikely that that would have changed the benefits from atezolizumab, where we've seen enhanced benefits when you give anthracyclines from the checkpoint inhibitors. So we know we're never going to have the final answer, but I think it really is an unfortunate result because it, I think, again, highlights the importance of the agent you're using, the population, and then the sort of small differences in trials over time. And, I think about this with the CDK4/6 inhibitors too. The populations change over time. How we treat patients changes over time. And so cross-trial comparisons are just very difficult, but they do result in the success or death of an agent in that specific setting it was studied in.
We can listen to you all day on just this topic itself. You bring up a good point on trial moving faster. I actually never thought about it this way, that you want to make a decision. Like, are we going to wait for this, or we just move on? Obviously, patient recruitment plays a key role in how long a trial goes. I remember Shepherd's coming about years ago, and I was still like, okay, it's not presenting yet. What's going on? So at some point, for your colleagues who are in drug development, are there any advice to say, get to decisions faster because it's better for patients and it's better for the ecosystem in general?
It's hard. I think using surrogate endpoints is really important, but what matters for drugs to get into the clinic and into patients is having an endpoint that the FDA thinks is sufficient for approval. And, in general, that's really what drives the use of drugs, even still now around the world. There are obviously drugs that are being used in the, huge patient population in China, which aren't approved here. But generally, they're banking on trials that have been done and have shown efficacy from that class of drugs. So I think that getting trials started as quickly as possible, trying to have them fit into what we would do in the real world is really important. And I think having endpoints that result in approval. And I think that this is the problem. PCR is just a great surrogate endpoint. But right now we need event-free survival. And of course, we like to see overall survival, but event-free survival appears to be enough for approval for the drug to be actually have regulatory approval. So how could you manipulate this to improve our chances of getting drugs into the clinic? And I think that what it really teaches us, and in this trial that wasn't done, it's just an agent issue, but in general, is that one size fits all trials are just no good and shouldn't be done anymore. We have to subset our trials. We have to be sure to incorporate biomarkers into trials. If you have a trial that's negative, but the trial has a negative result, but you end up showing that a subpopulation of patients benefited a lot, you can confirm that with a much smaller trial looking at that subpopulation of patients. Looking at PCR as a surrogate endpoint is really important because then you can go back and look at which of the patients benefited. And we now have, developing in these neoadjuvant trials, gene expression signatures, which help us understand which subpopulation of patients is benefiting more or less is also critical because, your result isn't going to be as good if you dilute out the population with a group of patients who would do well regardless of what you gave them. And I think that's also really important. In the I-SPY trial, my colleagues have developed an immune signature, as have many others. And if you look at the patients with the immune signature, there's also some data looking at patients who have stage 1, so node negative up to 2-centimeter cancers, who have a big immune presence, and they looked only at tumor infiltrating lymphocytes. Those patients in this one trial, which has been a couple of trials have been published, did well even without chemotherapy, but they would do really great with chemotherapy. So those patients have a great response. The immune signature patients do well. We don't know that all of those patients need a checkpoint inhibitor. If you have a lot of patients with a very immune active cancer and you give an immune cocktail, you might need a lot more patients to see a benefit because the degree of improvement is going to be smaller than if you have a group of patients who, for example, maybe benefit more because their chemo doesn't work as well. But the reverse might be true as well. So this is where you really need the results. And we actually presented at ESMO and published data from using an antibody drug conjugate to TROP2, datopotamab deruxtecan, and a checkpoint inhibitor, durvalumab, in the neoadjuvant setting. And what we showed, which was really interesting, was that the immune signature positive patients seemed to have this incredible PCR. So what you could do is think about the reverse. So if you find a subset of patients who have a marker which already responds well to chemo, but you can really improve it, what you could do with those patients is give them a much shorter course of treatment. And then you're curing this group of patients with less toxicity, less impact on outcome, less impact on society overall, because you have less toxicity and these patients are able to function normally with less long-term side effects. So I think that that's a way to get drugs into patients more quickly, is to really understand the biomarkers that correlate with response and to focus on specific subsets where patients may benefit the most, because then you get the drug approved and you can at the same time be investigating patients, populations where the tumor is less responsive.
That's amazing. As you were discussing PD-1 and PD-L1, taking you into the areas of bispecifics, do you see that playing out as we are looking to PD-1 IO and a VEGF?
Well, these bispecific antibodies are, to me, really exciting. And I suspect we'll be seeing, more on bispecific antibody drug conjugates too. And I think that that's, for me, that's very exciting because I was involved in the very early studies on into the phase 3 trials with bevacizumab. And I still have a couple of patients who are long-term survivors who received bevacizumab for metastatic incurable disease. And so, although the FDA withdrew approval because of toxicity and lack of survival benefit, I still wonder if it's just because we didn't have the right patient populations. I mean, we were doing these studies a long time ago, and we have really made huge advances in understanding subpopulations of tumors that might have benefited more. And we didn't really look at those populations. That's not the way the trials were designed then. They were much more of a one-size-fits-all. Even the post-neoadjuvant trial, I think, just wasn't designed in the way we would have designed a trial now. So based on that and the fact that I've actually given bevacizumab to some patients who've had radiation necrosis of the brain, so that's where you get radiation. We tend to radiate over several times, even with stereotactic radiation for patients who get these recurrent lesions in their brain. And when bevacizumab actually has been given with very good results for radiation necrosis in the brain at 2/3 of the dose we gave in the trials. And I thought, well, maybe the toxicity was all due to dose. And we would have seen a benefit at this level, because I've had a couple of patients who've had these amazing responses systemically because I added bevacizumab to their treatment for their radiation necrosis. So, that goes along with what I'd seen in the past. So these agents, I think, are exciting because they marry the two areas, giving a VEGF inhibitor and a PD-1 or PD-L1 inhibitor. And there are two agents, one PD-1 and PD-L1. I will say that we don't know that an agent is better because it targets PD-1 versus PD-L1. That has not been shown. There's never been head-to-head trials in the same patient population. What we know is the Atezo trial in the neoadjuvant setting was not positive. So I think both of these agents are quite intriguing and have shown, in combination with chemotherapy, remarkable results in metastatic triple-negative breast cancer, and are entering into planned phase 3 trials, as well as some investigator-initiated trials as well. So these are definitely agents to look out for. The drugs, there's others in development, obviously, with other companies in phase 1 trials, but these two that have already presented data at our most recent meetings, including at San Antonio, are really encouraging and exciting to me. And maybe that's the next step in further improving the results that we've already seen with pembrolizumab in triple-negative and high-risk hormone receptor-positive disease.
What to watch out for as the trials are being designed, and are there subsets that they should be really looking into? Because the last thing you want is wait another 5 years and things are not panning out.
It depends. I think, I think there are two ways to do this. One is to do some trials in combination in the metastatic setting. Antibody drug conjugates are clearly the path forward in more resistant disease, hormone refractory, and triple negative disease, ADCs have a solid place. They've improved survival. So adding, immune checkpoint inhibitors to ADC has been really an exciting path. And in the first line chemotherapy setting for triple negative disease, we've seen some really encouraging results from single arm trials, phase 2 trials. And so I think that path, which is being investigated in phase 3 trials, can be further explored with these bispecific antibodies along with antibody drug conjugates. So I think that that's a really exciting path forward. It's going to take a few years, but I think the way to try and move things forward even faster is to start with some early neoadjuvant explorations to see how these drugs are working in the neoadjuvant setting. So far, the toxicity from these drugs, again, these are smaller trials, still exploratory, and unless toxicity is really huge, you may miss it in these trials. But you're really looking for increase in immune toxicity, which hasn't been seen, an increase in hypertension or proteinuria, protein in the urine, that has been associated with bevacizumab and other VEGF inhibitors. And so far, the results seem to be quite, good. The toxicity is quite modest. And, obviously the patients were controlled in terms of having eligibility include controlled hypertension. But when we were using the oral tyrosine kinase inhibitors, the VEGF inhibitors, and didn't know a lot about hypertension, it was a huge issue, causing seizures, et cetera, in the very early days. And here, they're just really not seeing that. I think we've learned a lot about how to manage and evaluate those kinds of toxicities, and it doesn't seem to be a big issue. One other really interesting area for these drugs is what happens in patients with brain metastases. Again, because of the experience with bevacizumab in brain metastases and in, controlling neovascularization, even for non-malignant diseases. So that's another area I think of great interest. And I guess moving forward, it's nice to have a combination of investigator-initiated trials and sponsored trials. So while you're working on your path towards approval, and again, there are a lot of first-line trials, and the path, the sort of environment is rapidly changing. We expect to see at ASCO in 2025, so at the end of May, beginning of June, results from first-line trials with antibody drug conjugates in triple-negative breast cancer. Everybody wants to study triple-negative breast cancer. Remember, we're improving survival with the early-stage setting with checkpoint inhibitors. We're getting to the metastatic setting. You want to have patients, all these trials want to have patients who are relapsing more than a year after their last treatment with curative intent. That population is shrinking in the United States, thankfully. The patient population where we really have a huge unmet need are those patients who are relapsing early. But nobody wants to be in the situation of the impassioned trial presented at ESMO Breast, where atezolizumab did absolutely nothing in that patient population, and they had a terrible outcome. So I think you have to have a balance between trying to get the signals that help you move into a situation that really will result in use in populations that can afford the drug. I mean, this is a huge problem with just disparities in access to drugs, right? You might find a country that isn't using antibody drug conjugate in the first line setting after we see results from ASCO. We assume these trials will be positive. ADCs are moving earlier in the course of treatment. So should you be evaluating your new antibody in combination with an ADC in the first line setting or in the second line setting as rescue? You really have to think about what the future is going to be and where your drug is going to fit in the population that are most likely to use the drug. But at the same time, you want to be doing explorations in the early stage setting so that you know which population are most likely to benefit, so that you can rapidly move into that setting with the drugs that are going to be approved in the next few years in trials that are going on, looking at the benefit of ADCs in that setting as well. And, understanding this interaction between immunotherapy and ADCs is being studied aggressively by multiple trials. So the path forward needs to keep that in mind rather than be doing either what we call a Me Too trial, because you're going to take a long time to accrue and then it's not going to find a place. The first drug always getting used more, the first drug to get approved always being used more than others. Or doing a trial which includes a patient population that won't exist as much in the future. If we're going to be giving ADCs and these newer immunotherapies or maybe bispecific antibodies in patients who don't achieve a PCR, where are we going to put them in the metastatic setting when those patients recur? So I think that it's hard. We don't have a crystal ball, but we have to keep all of that in mind as we move forward.
You've been doing this for a while. Any learnings on the VEGF front as you combine an IO and VEGF? So VEGF's role in breast cancer, any gut feeling that people should be watching out for?
Well, that's what I was mentioning earlier. I mean, I think the idea of looking at the more aggressive cancers is really important. And we never found a biomarker that predicted benefit from bevacizumab, but I think that we're more likely to see benefit in triple negative disease and in HER2 positive disease. That's a very competitive environment where we have, such excellent agents now that it's hard to look at new drugs in the HER2 positive space like VEGF inhibitor, because we've got so many HER2 targeted agents. But I think that in triple negative disease, and including in the population that you evaluate for triple negative disease, particularly in the early stage setting, but in metastatic as well, the patients who have hormone receptor positive disease, but have an expression of the estrogen and progesterone receptor of up to or less than 10%, seems to be really important, because most of those cancers fit into the biologic subtypes that look more like triple negative disease, and you to a small degree expand the population that you can evaluate for efficacy. I think that also looking for a gene signature that would predict benefit is important. Managing the side effects very proactively is going to be critical. In the I-SPY neoadjuvant trial, where I'm the safety officer with my co-chair, Rena Nanda from the University of Chicago, we actually evaluate toxicity every single week. We talk to investigators about the side effects, and this allows us to really understand and manage side effects proactively. We don't, manage the fingernail soreness. We manage toxicity that's specifically associated with these novel agents, and that plays a really big role, I think, in development as well.
Great. And then I know you're excited about ADCs. I had a discussion, a town hall discussion earlier. The KOL mentioned that, oh, you're all just copycats. One person does ADC and 200 other companies run after
It's
ADC.
true.
So instead of being a Me Too trial, which is not differentiated and then it causing issues with trial recruitment, any thoughts on how to be streamlined on the development of ADCs as we go into the various sectors?
It's a really tough road, because the drugs that have been developed are quite similar across the board, and we're not understanding the toxicities well enough, because the toxicities are somehow related to the efficacy also, right? You're delivering drug to different organs.
Yes.
And so we don't understand that relationship well. And I think we're going to need data from more studies to try and make some sort of hypotheses about this. I mean, we have one TROP2 ADC that's approved, sacituzumab govitecan, but another trial that has positive results for datopotamab deruxtecan for progression-free survival, but had a negative result, no improvement in overall survival. So what does that tell us? I mean, we don't really know. I mean, we need to see the data that will be presented in this year to understand whether or not it's primarily the sequencing of agents. So for example, if you have a lot of ADCs available and you can give them in sequence, what is the impact of giving them earlier versus later? And we don't really know that. And so I think that that's a big question for the new agents, is sequencing and how drugs work in sequence. And if one, for example, TROP2 ADC worked well after another one, that might encourage you to switch the order or sequence differently. So I think that's one area that might help us a lot, rather than everybody doing a first-line trial, which is, of course, most appealing for the companies. We also at the same time want to be understanding the importance of sequencing. We want to know whether or not there are subpopulations who benefit, such as patients with brain metastases, or could you delay or prevent brain metastases with these ADCs? That's another really important area. And then we need to somehow understand this difference in toxicity and how it associates with efficacy. So far, we have not understood that well enough. But, for example, one drug, datopotamab, causes stomatitis. It causes less interstitial lung disease than its cousin, trastuzumab deruxtecan. But it doesn't cause a lot of bone marrow toxicity. Sacituzumab govitecan causes more bone marrow toxicity, and then due to its metabolite from irinotecan being the payload, causes diarrhea in a subset of patients. So these are really quite different. We don't know that they're going to, in the end, associate it differently with efficacy, but it's an intriguing question, I think. And I think back to when we were first studying nab-paclitaxel, and the first study that was done giving nab-paclitaxel after patients' cancers had progressed on paclitaxel or docetaxel showed this remarkable efficacy. And these are all microtubule inhibitors, and it's the same microtubule inhibitor when you give nab-paclitaxel after paclitaxel. And I think it's a lesson to look back to see, nab-paclitaxel is approved in settings in the metastatic setting, but it's approved after paclitaxel, and it's not approved in early stage disease, although we give it for patients with allergic reactions to the solvent or detergent in the approved drugs. But that drug should have been approved. And I think, one has to take the lessons from the past and move them into the future to truly understand these agents. The sequencing studies were so exciting. We should have been able to show that the drug was better than our standard agents.
Right. So in terms of sequencing, to your point, how do you see the ADC being sequenced in practice?
Well, we only have 2 that are approved right now.
Yeah.
So I think that what we've seen is that trastuzumab deruxtecan, which can be given every 3 weeks and is approved in HER2 low and positive disease, is usually the first drug we choose off the shelf. For HER2 zero disease, for triple negative disease, where there's actually a large phase 3 trial, we choose sacituzumab govitecan first. But in patients who are eligible for the other drug, we give them in sequence. The question we don't know is, should they be given directly in sequence? Should we give time for the cancer to upregulate a receptor? Will it do that? Is the key issue here resistance to the payload, which might not and generally doesn't reverse? We just don't know. There are a number of studies that are evaluating sequencing in the US and internationally. And I think that those will be really helpful. But again, as treatment patterns change, we'll have to take that into account as we evaluate the results. We often in clinical practice are giving these drugs in sequence. I would say that if patients are well enough, they get both drugs. And the when you give the drug first, which drug you give first or second really has to do with the ease of administration, hair loss, bone marrow toxicity, et cetera. So that's really why T-DXd ends up being used a little more frequently first before you get to sacituzumab govitecan. But for triple negative disease, that's really been our cornerstone of therapy. And I look forward to seeing the data in the first line setting. Keeping in mind now, and we learned that from TROPION-Breast01 with datopotamab deruxtecan in HR positive disease, that sequencing may impact the secondary endpoint of overall survival. We're now used to all these ADC trials showing survival benefits, and that may now not be happening as frequently. Of course, these drugs are also being moved into the post-neoadjuvant setting. So in drugs that have efficacy data, that's going to be really important, as well as their effectiveness in the neoadjuvant setting. The companies are all doing all of the same trials, and then how we decide which drugs to give is going to be important. So at the same time that you're doing your phase 3 trial to show efficacy, you want to be doing some sort of sequencing, even investigator-initiated trial, which I think is the easiest way to do those, where you can understand where your drug is going to fit into a paradigm where the first drugs for approval generally are still the drugs people reach for.
We discussed chemotherapy a little bit, and I do have a selfish reason for this question. Back in the day when I worked on IO as part of the industry, we thought IO was going to displace chemo. It seems like chemo is still here to stay, even in the breast cancer setting. Where do you see chemo holidays as well as chemo in the rest of the world? Because as we advance in the Western world, rest of the world still sometimes don't have IO or ADC and other agents. Advice for colleagues the rest of the world on what chemo to reach out to, and even having a chemo holiday in the Western setting.
Chemo holidays are a tough situation. We've seen that if you have a holiday from chemotherapy in a number of trials, most recently a phase 3 trial now a number of years ago in Korea, that in triple negative disease, once you have a response, if you stop treatment and then restart when the cancer grows again, that survival is adversely impacted. So patients have worse survival. In hormone receptor positive disease, you can use hormone therapy and a CDK4/6 inhibitor for maintenance, but two trials actually have recently shown that if you give a CDK4/6 inhibitor and endocrine therapy, the right choice, and most recently the PADMA trial, that patients' outcome is better compared to either combination chemotherapy or even single agent chemotherapy in a standard of care setting in the PADMA trial that was presented at San Antonio. So that sort of concept really goes by the wayside. Once you get to chemotherapy, you don't really have a maintenance strategy because you've presumably used up your endocrine therapy and targeted agents. Sometimes we see these somatic mutations in HER2 or BRCA, but what drugs we can access, people are not accessing in countries that don't have access to IO. They're not getting those targeted agents. So chemo holidays remain a challenge, I think. Keeping in mind the fact that our goal in treating metastatic incurable cancers is to help patients live as long as possible, but with the best quality of life. So taking a chemo holiday and going on a month-long vacation that you've always wanted to go to do something, or because you have a big family event, or because of toxicity, this has to be balanced. And there's certainly no data that impacts survival. It's waiting until the resistant clones outgrow that really is the problem and should be avoided if possible. It just depends on the patient. And like everything, treatment has to be individualized. In terms of chemotherapy, we also saw, and I hope to see updated data from this in the not too distant future, but a trial from Tata Memorial Hospital. I mean, it's just amazing what trials they can do. They two trials recently, I think, really impressed me, and how much the trials cost to do is also impressive. But there are other complications, of course, in terms of what therapy patients have available to them in sequence, which I think is going to be an increasing issue for the FDA when they're looking at results from trials. But this trial is very simple. It was a very large neoadjuvant trial enrolling women with triple negative disease. Over 700 patients enrolled, but it took them a long time. And they basically just looked at whether carboplatin improved outcome. And it did. And intriguingly, it improved outcome more in younger women than older women as neoadjuvant therapy for triple negative disease. And I think that people said, well, we already knew that, we're giving IO, so it doesn't matter. And I thought, no, I mean, this is really an incredibly important trial, because you could potentially devise the next trial for, availability for drugs is going to be an ongoing issue. I mean, they're very costly. People just don't have access to them. In most countries, the government is deciding what patients can have access to or not, unless they have private insurance or deep pockets. And I think, so for that reason, trials can be done looking at chemotherapy benefit, but then rescue with these drugs. And to me, that could be an appealing mechanism to allow the governments to pay for drug, because you're taking the initial treatment, and for example, you give your platinum taxane treatment, and if you don't have a great response at 4 weeks, you add in the checkpoint inhibitor. Therefore, you're reducing the overall cost of treatment. So to me, chemotherapy is definitely here to stay. Chemotherapy is the important part of the antibody drug conjugates, along with their immune effect. But we could still improve on this to allow better access around the world and better use of the drugs.
I'm excited to hear about the Tata study. That would be interesting. We do want to borrow you for 3 minutes at the end for a PSA. So we'll wrap this portion up in the next 5 minutes or so. What are you excited about as you're going through some of the studies, some of the trials that you're sitting on as part of different committees? What excites you?
I think that, we've been very, very excited about the success of cyclin-dependent kinase 4/6 inhibitors in hormone receptor positive early stage disease. It's important to keep in mind that breast cancer is the most common cancer diagnosed in women worldwide, but it's also the most common cause of cancer death, not in the US, but around the world, globally. And the most common subset, so the most prevalent subset of breast cancer is hormone receptor positive disease. So I'm excited about several areas here. One is understanding better which of these subsets responds to chemotherapy and checkpoint inhibitors. These are younger women who have really aggressive cancers. If they act like triple negative cancers, we should be treating them that way. because I think we'll be able to improve outcome in those patients. I think the biomarker analyses that are going on for these trials is also going to be critical to allow us to select patients. And again, that might improve the use of these drugs worldwide because you're selecting a patient population who specifically benefits. But again, money ends up being a big issue here. I understand. I mean, there's some countries, even though Olympia showed an improvement in survival in patients with high-risk BRCA associated cancers, giving olaparib, the PARP inhibitor, there are some countries that still have not approved that for their patient population. So we know it's not just about those issues. So I do think that in hormone receptor positive disease, there are some really exciting areas. We've understood now that there are new hormone agents, finally, after the aromatase inhibitors and fulvestrant, that may be able to improve outcome in specific subsets of patients. And these drugs, the oral selective estrogen receptor downregulators, Protex, Ceran, Sirtex, they're all different drugs that affect the estrogen receptor, that they're moving into the early stage setting where we'll have results from trials in the next few years, maybe improving outcome in that patient population by switching using a sequencing approach, which I think tackles the idea of emerging resistance to endocrine therapy. Along with targeted agents, I think that this is really exciting. And of course, trying to separate the wheat from the chaff, really, taking the patients who really need immunotherapy and chemotherapy and treating them with those agents is understanding primary endocrine resistance, really important and exciting new approach. I think the whole idea of study designs now, where we're really focusing on specific subpopulations, is important. Even within triple negative disease, really understanding these patients with rapid relapsing disease and changing therapy early, like we're doing in the I-SPY trial and some others are investigating, is important. We talked about the importance of antibody drug conjugates. When we see drugs that can improve survival in bad disease situations, we want to get them into patients earlier before you have so much resistant disease, with the idea that we may cure more patients. And at the same time, I think we're evaluating safety carefully to try and approach safety issues proactively so that we understand safety, we monitor carefully for it, we treat appropriately, and in the right settings, we use preventive strategies to avoid the toxicities that we can see. All of these things, I think, are really important as we move forward in the next few years. The new agents, the bispecific antibodies, I'm really excited about as well. And then, lastly, I think this elusive goal of trying to turn cold tumors hot, and that idea of adding checkpoint inhibitors to antibody drug conjugates is exciting. I think that it will need to occur earlier in the course of treatment. Understanding the optimal duration, the optimal setting is really a challenge that we all need to address moving forward.
This is fascinating. We could listen to you all day, as I said. I wanted to thank the team members and the peers that have joined us for the town hall. If you don't mind staying with us, Dr. Rugo,
Of course.
I will let the rest of the team go.
I will just say one last thing, which is one really exciting approval that occurred this year was the alpha-specific PI3 kinase inhibitor inavolisib. We didn't talk about HR-positive disease much, but that included a group of patients who have this primary endocrine resistance and mutations in PIK3CA, which occurs, it's the most common mutation in hormone receptor positive cancers, about 40%, 30 to 40%. And that's led to a lot of interest in how to study these triplet combinations where you give a targeted agent that targets a pathway that's driving resistance, a CDK4/6 inhibitor based on really intriguing preclinical work by our colleagues, including Sham Gol, and then an endocrine therapy. And, because in all of these areas, we have improvements. We have new CDK4 inhibitor, for example, that might work well in that setting. We have new endocrine therapies that may improve on fulvestrant. Inavolisib targets PIK3CA, but what about using an AKT inhibitor? Would that make a difference? Should we be studying this in patients who don't have mutations in PIK3CA? There are a lot of great areas to study here. And once we have a better handle on it, this is something we may be able to bring into the early stage setting to target these patients with primary endocrine resistance much earlier in the course of treatment.
Great. Thank you so much. And I'm sure between now and ASCO, there will be plenty more data sets that
Absolutely.
we will be going back and forth about. Thank you.
you.